That leads us to shorter implants. So we're going to start, we have nerves. Look at it changes the crown to implant ratio, doesn't it? Look at the huge clinical crowns compared to these resorbed mandibles. And so we have to look at these things. Here are these real short implants with the nerve sitting right over here. And so there are multiple ones, we're splinting them, but these are kind of weird. These are different than I ever thought I would ever use. So these are 6 millimeter tall. I know in Europe, 3i is experimenting with 5 and 6 millimeters on the marketplace. Hopefully within 6 months they'll have it. This happens to be an Astra implant. I'm just showing you that, or you can use an ITI that has one piece. But you have to understand that we're looking at short implants. But what's the risk here? Do I want a platform switch here? Absolutely. Why? Because I have less bone loss down the sides. A platform switch implant, our own work even on the Prevail from 3i with the Borg group from Spain, instead of the classic 1.5 millimeters down the side, it's about 0.5. And this is what we're seeing on most of the systems today, 0.3, 0.5 average. That doesn't mean they're all 0.5, but those are averages. And that's good compared to 1.5 to 2. That means my crown to implant ratio, which is short to begin with, is at least, if I start with a 6 millimeter implant and I lose 2 millimeters, I've lost 33% of my support. Now with a platform switch, I might only lose 0.5. So at least it helps my crown to implant ratio. And that combined with splinting seems to do the trick. And you see these short implants that we're using on some of these cases where the nerve is high. We don't want to build it up. So this is the Prevail implant. This is the main implant that I tend to use as a tapered implant. We should mention wide tapered because you have much better stability. Now, 3i got a little hurt. So did Stereos, by the way, on their original tapered implants. Let's talk about this openly and honestly. The first implant was too tapered. And because it was tapered, everybody got this wedging effect, so they thought everything was fine. But what happens? It wasn't as binding because the thread pattern, notice these threads are much sticking out, big time. And this is what we like. It gives us tremendous initial stabilization. And it also increases surface area again. Now before, these weren't there. It was just a tapered body without the threads. And same thing with Stereos. You know that you can't find articles on the original Stereos implant, the tapered implant? Because the success rate was not as high as the 95 to 98% that we expect today. Why? It wedged in, but it wasn't doing the job that we thought because of the fact that we just counted on the body taper. It didn't really bind the same way into the bone and grab the same way these do. And we lost a lot of surface area. Remember, for every millimeter you increase or decrease, you lose how much? If I decrease the surface area from a 4 to a 3, how much surface area have I lost? About 25%. If I go from a 4 to a 5, what have I done? I've increased 25%. If I go from a 4 to a 6, I've increased 50% surface area. So here's where we're going to go. Here's the paradigm shift for you. We're going to, on short implants, I want as much width as I can get. And sometimes we have that. On the sinuses, for example, very common. You have a broad, fat ridge, but it's short. We may be looking, in fact, the data is pretty clear, coming a lot out of Europe, and also we're doing it ourselves, that we're seeing that if I have 6 millimeters of bone under a sinus, I can electively not do an osteotome. And especially if I have width to compensate for the shortness. We're all looking, and we don't know what's going to happen in 10 years, but we're all looking at the possibility. And there's some very good data coming out of Europe on multiple systems, talking about using 6 millimeter high implants with different widths. That could be 6 millimeters wide, could even be 8 millimeters wide. It could even be 9 millimeters wide. So the big companies are afraid to get involved right now. They're all a little stuck, every one of them. They're not showing these big wide implants. So the young upstart companies, kind of like 3i was with Lazara at the beginning, Implant Innovations, will make anything for you within a day. Well, that's what these other companies done, particularly in Korea and so on. So you got Southern Implants from South Africa, you got Megagen, you got Dentium. You have all these companies that are trying to take the niche away from the big companies. And what are they doing? They're making wider ones, shorter ones, fatter ones. The other companies, the big ones like 3i, they're on their way. They're going to be there, but they're afraid to make a mistake. So they're, because they're the standard. They're the excellent ones. So we're getting them there, but they will. And there's rationale for it because of the percentage of bone that you will increase with every millimeter you increase. So on short ones, we want a platform switch to make sure we don't lose too much bone down the side. And the bigger the platform switch, by the way, the less bone we lose down the side. Canulo did that work. So the wider the platform switch, actually the better off it is in terms of even getting less bone loss down the side. There's room horizontally for the epithelium and connective tissue to protect the bone. The irritant is further away from the bone edge, and so therefore there's more protection to the bone. Is that clear to everybody? So you see that here's the ankylosing implant. You see that there's a biologic width here, but it's on the abutment. This was an immediate loaded case on a monkey. This was immediately loaded on a monkey, and George Romanos put these abutments on and never changed them. So that's why, where's the biologic width? It's partly horizontal and partly on the abutment. See, the crowns are up here. This was never changed from the day of placement on this monkey. So what you're seeing here is the potential for biologic width to stay there, and this is even after 9 months of loading. So it stays. It works. So these are the kind of things that I need you to see. Okay. So, and when you see beautiful pictures like this is from Todd Berglund, this one's with an Astra implant, what you see is that this abutment was never taken off. Remember that. This was never disconnected 4 times. That's why it's still perfectly sealed, and the biologic width, that's why there's no bone loss down the edge of this, just a little bit on the bevel, and that's it. Where's the biologic width? Almost completely on the abutment, and a very little bit on the bevel. Got it? So can biologic width always exist? So just don't look at an x-ray and say, oh, we don't have a biologic width. You know that it's on the bevel or on the abutment. It was never changed. Yes? Canulo did what? They did no platform switch on this implant. They used different widths with implants with the same abutment. No platform switch, control group. Test was 0.25. The next one was 0.5 and then 0.85. And this is human study, by the way. This is not an animal study. I love this study because it shows the whole principle in a nutshell. Because what you're seeing here is, let's take a look at the bone loss. First of all, what you'll see in a moment is that the bone loss on this implant is going to be about what? Yeah, if you reconnect and disconnect, yeah, it's going to be about 1.5 millimeters. That's exactly right. What's beautiful about is that all these implants all did better significantly. So let's take a look at 9 months. There's your 1.2 millimeters at 9 months. This is a radiographic study. This is humans. Notice that all of them dropped off completely, under 1, 0.7, 0.6, 0.4. Notice that the bigger the platform switch, the less bone loss down the side of the implant. Got it? You know what I love about this study? It also showed that it's the same pattern went up to 33 months, almost 3 years. He's showing that it didn't lose itself, that the same pattern of success was there. Here's your 1.5. Look at that, 1.49 at 33 months. And then these were 0.6. You know, when you have a good platform switch, it's about 0.5 millimeter. So what I need you to get, though, is that platform switching is 3-dimensional. Why is it here to stay? Oh, it is. And you'll see when we get to the clinicals how important this can become. Where do you put the implant was part of what you asked me. So that's why I'm putting this in here. Then we'll talk about the height after the break. But let's talk about a typical socket. If you put an implant just in the middle of a socket, with no platform switch, just a regular implant, this is about the zone that we find, that the horizontal component of the biologic width is about 1.5 millimeters. My research in the year 2000 showed that the horizontal component, everybody was always talking about vertical. How much the first thread, second thread. And I realized in 2000 when I was looking at the papilla discussion of how close you can get 2 implants next to each other, I realized that the horizontal component was a factor. And what did I show? 1.4 millimeters. So that's why I came up with the 3 millimeter rule. If you don't want to lose the crest of bone, stay about 3 millimeters apart. So can I borrow 2 of you? Why don't you guys come up? Jose? That's easy. Both Jose. Come on. Jose 1, Jose 2. Come on. I know you don't look like lower anteriors, but come on. Come on. Come on up here. Come on. Problem is, neither do I. Sorry. Take a look. These are my protectors last night. Come on. My bodyguards. I have pictures with them. My bodyguards. Okay. At dinner. All right. So let's say these Jose 1 and Jose 2.
I'm Jose 1.
You're Jose 1.
Yeah.
You are Jose 1. Okay. So you're Jose O. Yeah. Okay. Oscar. Okay. So they're both lower anteriors. Okay. And Jose 1 here, he gets a little dirty. He's not cleaning himself too well, you know? She definitely does. You know him. She definitely does. All right. So, you want to talk about this or what? Okay. Now, I'll shut that up. Now, he gets a little plaque on him, his lower anterior. These are teeth. Now, how far, will he lose bone? Will Jose too lose bone? If he starts to lose attachment, will he lose bone too? What kind of bone loss do we tend to see in the lower anteriors initially, between two lower anteriors? Do we see horizontal bone loss, or horizontal or vertical bone loss? Does the whole thing go down, or do we see angular defects? We usually see what? We see the horizontal bone loss, meaning the bone loss is lost completely. In other words, we'll lose the crest completely. So how far away there's a lateral toxicity to plaque, not just vertical. So as plaque marches down the tooth, you got bone loss down the side, but there's a horizontal component to it. And that's probably as, if not more important in some respects, with teeth and implants than the vertical part. Because how far away do they have to be? If at the normal distance, they're going to both lose bone. Even though he is not in trouble, he is losing bone because they share the same bone. And they're closer than what? They're closer. How far away do they have to be for his bone loss not to affect him, that he'll form an angular defect? How far away? 2 millimeters is the minimum number shown. Chaim Tal did that study and actually showed that the minimum distance is a little greater than 2 millimeters. Anything under 2 millimeters, he's going to affect him. Got it? Otherwise, and that's what happens. Now, let's say he starts to get full of plaque too, and they both start losing independent bone. How far away do they have to be? I'll be the bone in between, okay? I'll be the in between. I'm the crest. Never did this before, but okay. Here we go. Now, I'm the bone crest. Now, I don't want to be lost. I like my head right where it is, see? Now, I don't want to be lost, but what happens? If these guys are too close together, he has a horizontal component, and he's got a horizontal component. So what's going to happen to me? I'm gone. Now, how far away do they have to be to form two angular defects with the bone maintained between? What's the minimum distance that you will tend to see? About 3.1, as we showed in humans. So that's exactly right. Now let's make them implants. Okay? Okay. Let's make them implants. And we attach a connection without a platform switch. How much bone down is he going to lose? 1.5 to 2. How much bone horizontally? That's the 1.4 that I showed in the year 2000. So we know to keep the crest of bone, to help support the papilla, they have to be about 3 millimeters apart. Now let's say I'm the buccal plate. I'm over here. I need you to see this three-dimensionally. We only looked at the interproximals. What happens interproximally, does it happen on the buccal and the lingual? Yes. So if I'm the buccal plate, how far away do I have to be from him not to be affected by him? Without a platform switch? About 1.5 to 2 millimeters, exactly. So this is very important. Now let's watch this on the diagram. Thanks, Jose, 1 and 2. Thanks, guys. So let's put this together. And let's tie this up, and then we'll have to take a coffee break. Put the implant in the middle. Thanks, guys. I put the implant in the middle. There's a horizontal zone, and it's three-dimensional. It's around the whole implant. It's not just interproximally, as we see on an X-ray. It's buccolingual. So what happens is that if you get too far buccal, what's going to happen? You lose the crest. That's why everybody talks about, I want the implant 2 millimeters away from the buccal crest in the aesthetic zone. Why? Because they want 2 millimeters of buffer zone. It's all about biologic width, the horizontal component of the biologic width. Well, that's without a platform switch. See it? You use that crest, you got increased recession. What's the other thing? How close can you get to another tooth? If you're under 1.5 millimeters, Esposito showed us that in 1993. We used to think it was just from injury, trauma, but it's really biologic width reformation. He showed that if you were within 1.5 millimeters on a not platform switch implant, anything under 1.5, there was always crestal bone loss on the adjacent tooth radiographically. And as you got even closer, you lost more bone. And right there. So these are the problems. And what happens when you put a platform switch implant in? Now, we did this article. This is on the 3i implant. This is the Bohr group, Rodriguez and Vela Nabat and myself. I helped them with this data. And the effective distance on the height of the interdental bone crest when using platform switch implants, and we did this in 2009. And we showed that instead of 1.5, the horizontal distance with the Prevail implant was 0.6. That's a millimeter difference. Instead of 1.5, it's about 0.5 millimeter, 0.9. This is a big difference on both sides. And the buccal. So instead of the 1.4, that's what we found. Okay, and this is what I showed you with cannula. Now, what I want you to see is what happens if we put a platform switch implant in. So we go from this, that's the zone, right? That's the zone around the entire implant. Put a platform switch implant like Prevail or any of the platform switch implant, what's going to happen? The same width implant, that zone of influence or zone of destruction is going to shrink in. How far? Almost a millimeter. It's going to shrink in a lot. It's going to shrink in down to about a half a millimeter. And if it's a real wide platform switch, meaning it's narrow, it's even going to be better. But this is just the normal one that we've seen. That allows you freedom to have a little, use this in a little bit limited space, both buccally and interproximally. So like a lateral incisor and stuff like that, or lower anterior, so it really shrinks in. So this is what we can do. It allows us a lot of freedom to do that. Any questions on what this does? Any questions on that? Yes. Yes, and that's why I said every implant in the future, almost every. And the only place that might be a limitation is a single molar. So let's make Jose one a molar now. Or you're Jose two. You're Jose one. Sorry. So Jose, he's a molar, and here's the first molar. He's the second molar, and I'm sorry, you be the bicuspid. He'll be your first molar. You'll be the second molar. Now, when I take him out, there's a big space, mesiodistally. So now, prosthetically, if I have a very narrow entryway, meaning the abutment connection is too narrow, I have to come up and get to the contact points. I make funny shaped crowns. So this is the one negative on a single molar that has, let's say, 12 to 14 millimeter distance. It has an odd shape. So what do we do with that? If we're using a platform switch, you put it a millimeter below the crest. Make sure you don't violate the nerve, but it gives you a little more running room to get to the contact points and creating smoother profiles. That's the only place I've seen as a potential negative of is a single molar wide distance between them, but it's a minor one, and we just place the implant surgically. Those of you in the room doing surgery, place it just a little bit lower and gives the restorative dentist more running room to create a more shaped contour, okay? Does that help? But otherwise, there's no reason not to. Is it important to do this and when there's plenty of bone interproximally and there's plenty of bone on the buccal? It won't matter. And I'll show you after the break cases where I put them in before I was using platform switching, and it was perfectly fine. I got a beautiful result. Why? Because the distance next to an adjacent tooth was greater than 1.5, and the distance to the buccal plate was greater than 1.5. So then it doesn't matter. But if you're less than that, it becomes more critical. Got it? Just use a little more freedom and a little more playroom surgically and restoratively. Okay. Last piece. Can gold integrate? I challenged your mind today. Can gold integrate? If I machine gold, same as I machine titanium, like Brandemark did, and I put that in, could gold integrate? There's no oxide on it. I texture it, I put it in, I sterilize it, and I put it in like I did original Brandemark implant. Can gold integrate? How many people say yes? How many people say no? And people don't know. That's fair. Yeah, it's about a third. Many of you have probably read this article, those are the specialists probably have, that the answer is yes, it can. And this was Abramson's article showing that if you use a fully gold implant and a fully titanium implant, if you machine it the same way and create a certain roughness to it, that gold does integrate and like titanium, and it may have a little bit less roughness in the bone deposition in the marrow, but the same was in the crest. You know what else was interesting from the restorative standpoint, people? That the gold had the exact same biologic width at the same level as the titanium one-piece implant. There was no difference between a gold abutment, for example, and a titanium abutment. And in the literature, when you see that, articles that say, oh, the gold abutment didn't do as well with epithelium, that's because we had garbage on it. It wasn't sterile out of the box, whereas titanium was. So we have to be careful about what we put in, what's on the gloves, what kind of paste is on there, is there rouge on it? Epithelial cells may not like rouge. They want to be clean, they want to be sterile. But I want you to, you'll understand where I'm going with the clinicals. It'll be a lot easier now that we've done this, the basic science. But notice the shape of this implant that you see there. Is there any implant you know recently that comes out with that basic design, that basic thread pattern? Does it look too far off from that if you look at the general design? Now this was a Tremonti screw. This is the Nobel Active, and this is the Tremonti screw. Now, how come the Tremonti screw, now, by the way, you go back to this history here, you look at these old ones, most of them were from Italy. And it's rather interesting, most of them are from Italy, and you just know that when you look at some of these, they look like corkscrews. You know that the guys had a couple of good bottles of wine the night before, and they probably said, hey, what do you think? Let's try it in bone, it's a corkscrew. And that's exactly what happened here. But why did this implant, that was 1963. Now, it's the same shape, more or less, self-cutting, same shape, big threads as this. So why is it that that one didn't survive? You tell me now. Now look at that, and it's not much different than that. Huh? Right. So let's open our minds. If I'm doing anything, I'm trying to expand your thoughts. So here was a screw that had a similar basic locking in mechanism. The concept of the screw is the same. Now you could change the pitch a little bit, maybe put double screws. It really was doing the same thing. And I'm sure when they first put it in, it was solid. But what was the problem? They couldn't get integration to it. They didn't understand what integration was. That plus improper loading during the healing phase. Those are the two things. So let's go through this real quick. That if you have an implant with a polished surface, it's not going to take, other than whatever mechanically you get out of it. So where do you want to use these screws? Where do we use these now? Something like it. What about when you do a block graft? How come you can go back in 6 months and give it a little crank and the screws come out? Because they're polished. They don't integrate because they're electro-polished. You understand? So that's why your bone screw set is a polished screw. They're not rough, textured screws. Getting the understanding now? So it's all understanding the biology allows you to understand. Same thing with your TADs, any orthodontic screw. You want to wrench them out. You get the physical locking of a screw, but not the integration. Two different things. Got it? All clear on that? So we could have saved Nobel $200 million. I could have given them that knowledge from 60 years ago, see? But they decided to spend $200 million on something. So the 4 reasons the platform switching helps, we've covered most of these, short implants to improve the crown to implant ratio, yes? 2, minimize the potential of mid-facial recession. 3, allow implant to implant dimension to be potentially less than 3 millimeters, and our research now shows that I can get it even as close as 2 millimeters without losing the interdental crest. That doesn't mean you can immediately get a papilla back. What are you still missing? Supracrestal biologic width. You must still get, for a papilla between 2 implants to form, we must still have the idea of getting attachment on the abutments. And allow an implanted tooth dimension to be less than 1.5. We're down to 1 millimeter now with a platform switch. Where is that? Like a lateral incisor, lower anterior? So if we used to say we want 1.5 millimeters on either side, and certainly if you have the room, that's great. But if you don't, use a platform switch implant, and you can probably get down to 1, because the dimension horizontally is about 0.5 or 0.6. So we still have a 0.5 millimeter, buffer to not injure the adjacent tooth. Fair enough? So there's your big 4, as far as I'm concerned. Excuse me. Let's see what we've learned. I point to an implant. You tell me where the bone loss is going to be after, let's say, 6 months with multiple changes. No platform switch on these implants. Real quick. This is a typical Brandemark type implant. Plate them all right up to the crest. Every implant's placed right to the crest. Now, this one, about where was the bone going to go? 1.5 to 2, about the first thread. Now, this was a 4 millimeter polished collar. This wasn't this was meant to wedge bone grafts in. This is actually what was from Nobel. And what you see here is that this was put at the crest. It was not sitting up like a tissue level implant. Now, this is 4 millimeters polished collar. So where did the bone loss go down to? First thread, right. They lost 4 millimeters of bone because of lack of understanding of what osseointegration really is. So this was a major disaster because everybody lost 4 millimeters of bone with this implant. Now, although these are all different, about where will the bone be on these implants? First thread, about 1.5 to 2. Now, this is a 3 millimeter polished collar. It's a shorter version of 2. So, first thread. First 1.5 to 2, kiss goodbye. Without a platform switch, first 1.5 millimeters is going to go just for, you need the room for biologic width, minimum 1, usually about 2 millimeters. Then if it's polished, it keeps going down till it gets to the rough surface, which is inside the threads, the striations. Now, this is the real test. Number 9 is the test. Number 9, shape-wise, is the same as number 2. 0.5 millimeter polished collar. First thread is 4 millimeters down from the top. Place the implant in, multiple changes, no platform switch. You have 3 choices. It stops at 0.5, it goes down to 4, or it's somewhere in between, about 1.5 to 2. You made my day. As a teacher, nothing makes me happier. Because when we started today, if I showed you this, I don't think you would all have the same answer. Now you're on. Now, how does platform switching? And look at the smiles on your faces. If you look at each other, I know you don't want to look at each other, but look at each other for a second. That smile on your face means that something registered. The bulb went off. The bulb went off just now in some of you. It finally put it all together. Just that simple little understanding of this. And here's what's beautiful about this. It will never change. This will never change. Now, granted, the implants will change. You could have platform switch designs will change. But the biology that you just saw and delivered to knowledge to look at something, and you can now look at any implant design and start to figure out about where the bone should be. Not because some company tells it, because you understand the wound healing. And you know why it doesn't change? Biology doesn't change. Wound healing doesn't change. The implants will change. They'll change design, roughness, and everything. But the basic principles of this wound healing that we discussed this morning will not change ever. Okay? So you can smile. It's a good thing. Knowledge is wonderful, and that's what it is. Okay, let's get to some clinical work. And I'm going to work on sockets. We're going to work with this quite a bit now and put this together. So what I want to go through, and it'll cover a lot of the things that are left over there, worked on this here, is how does socket anatomy affect our treatment plan? Does the gap distance matter, which is one of your questions, and does immediate placement preserve the buccal plate of bone? So let's talk about first how does socket anatomy affect our treatment plan. What you see here, I came up with a socket classification. It's very similar, it's not identical to what Garber and Salama have. This is more related to interproximal bone and buccal bone, but this is strictly related to the buccal plate. And that is when we take a tooth out, and I mentioned this in the year 2000. We finally published it in 2007. I had put Elliot in as the first author. But it basically is very simple and straightforward. A type 1 socket, everything's there. It looks great. Although the bone is there, everything's good. A type 2 socket is different. This is what is deceptive. Type 2 socket, the soft tissue is there. It looks the same as a type 1, but the buccal plate is partly or completely missing. And that's important to differentiate. The differentiation of just this type 1 versus type 2 will either get you into trouble or get you out of trouble. Not understanding that one little simple thing is going to be a big difference in the aesthetic zone. Now, type 3, nobody gets into trouble with type 3. Why? Because there's already recession before you started. So nobody gets into trouble with type 3 because they know that it's the most difficult. They got to regenerate soft tissue and bone. And so immediately you know, hey, let me regenerate the tissue and bone and then come back to it. So, but where do people get into trouble? Shh. Type 2, the number one thing I see is mid-facial recession. If I had to give you one clear thing that I have to fix more than anything, and I'm sure most of the periodontist neurosurgeons will say the same thing, it's mid-facial recession on an implant. And it's all because of placed immediately. I cannot begin to tell you how many patients come in and say, oh, the doctor put it in immediately, told me it would be great, and then it integrated. No one's questioning the integration because you got all this bone up here to integrate to. But the question is, what does it look like aesthetically? And that's where the mid-facial recession takes place. Now, there are three sources of blood supply to the buccal plate. There's, of course, the ligament. And the ligament is very vascular. People think it's only fibrous tissue. It is extremely vascular because it has to deal with occlusion every day and adapt, doesn't it, for all of our lives. It may be even as much as 20% vessels and the rest fibrous tissue. So when you take a tooth out, of course, for whatever reason, we've taken away the ligament, number one major vascularization of the buccal plate. What's number two? It's the buccal periosteum. Now, this is an important point. If you're going to walk away with anything, some of you have heard this before from me, but if you're going to walk away with anything, it's you are no longer going to open flaps to take teeth out anymore unless they're impacted. Forget it. No mas. No more. You say it in any language you want. There is no way. You raise your right hand. I promise, Dr. Tony, that I'm never going to open a flap again to take a tooth out. If you get into that mind, you will never open a flap again. And I got to tell you how hard it is for oral surgeons and periodontists to get out of the habit, as well as generalists. But even top specialists are so used to doing it. Oh, I'm taking a tooth out. Give me my scalpel. Let's open a flap. No, not unless you want to add something valuable, and we'll talk about what you need or not do. But if it's all there, leave the damn thing alone. Do not disturb, okay? And because you're only going to hurt yourself and the patient, as you will see. Because if you lift it up, and people think, Dr. Tano, look, here's my case. I don't understand why I had a problem. Let me see the case. I took the tooth out. I opened the flap. I said, Okay, you open the flap, and then what do you do? Look, I put the tissue right back. Didn't I suture it nice? Didn't I do a clean surgery? I don't see what I did wrong, and yet I got recession. You know what it was? They opened the flap, and just because they put the tissue back beautifully and sutured it so perfectly, they felt that they didn't do any harm. Give me your finger. How would that if I cut his finger off and then I put it right back? Would that bother you? Oh, go ahead. I'll make it look nice when I suture it. I'll do a great suturing job. You got to be kidding me. Just because you open a flap and you put it back doesn't mean that you haven't injured the bone. In fact, you have, because you severed the blood supply. So even though you masked it, you have cut the blood supply for how long? About 4 to 7 days before the reanastomosis of the blood vessels take place, even though you opened it and put it right back. 1 minute, that's all, 30 seconds, 1 second. So, and by the way, don't give me the stuff like, I did a mini flap, Dr. Tarner, I did a mini flap. What's a mini flap? Oh, I only opened up the first 2 or 3 millimeters. That's like being slightly pregnant. You know, either you did it or you didn't do it, you know? You got to be real. I'm being dead serious. This is a serious thing. And that's exactly the crestal bone that I want to preserve, and you just opened the flap right on that part. The most important part. So look how silly we are. And that's what we've been doing all of our careers. Now, what data do we have, and what's left? You got the marrow. And is there marrow? Well, the marrow, how much thickness of bone do you need before you really have marrow instead of just cortical bone? Anybody know? Didn't I give you the number? It's usually about 2 millimeters. In order to have 2 plates of bone and marrow, it's usually over 2 millimeters. So not far from 3, but it's at least 2. So it's 1.5 is not enough. Certainly 1 millimeter for sure has never been shown to have 2 plates of bone with marrow in between it. Never been shown. So now how thick is the buccal plate in the 6 anterior teeth of the maxilla? What do we know about this? Do we have any measurements? I know it's a very personal question, but how thick is your buccal plate? 1.5 to 2. I wish it was 1.5 to 2. That's why you get a 90, but you don't get 100 on the exam. So take a look at a recent article by Mariano Sands. They looked at 93 anterior teeth, and they opened flaps, which as you know, I don't believe in, and you'll see why. They opened flaps, and they measured the thickness of the buccal plate 1 millimeter up. And what did they find? Read it and weep, people. Look at this number. What do you see there? 0.5. 64%, 2/3 of the maxillary 6 anterior teeth, the buccolingual thickness, 1 millimeter up, was only 0.5. And another group, 23%, was about 1 millimeter. So 90% is 1 millimeter or less, and most of them, 2/3 of all our 6 anterior teeth, this is humans, not animals, was only 0.5. So if you pull a tooth out and take away the ligament, if you open the flap, you have temporarily for a week destroyed the buccal blood supply to the buccal plate, even though you put the tissue back over it. And so what's left? This thin piece of buccal bone. Is it going to survive easily? The answer is, is no. Period. It's going to tend to go through resorption. So what do we have? What kind of numbers do we have out there? What do we know about anterior flaps, and what do they do? When I first looked at this data, I put this together, and of some of the key articles, there are some others now, but to look at the articles in humans. I'm not talking about animals. I'm talking about humans. And say, what has been shown in terms of the buccolingual dimension change and the height change? The good thing is you look at the vertical change at 6 months, and most of these are doing pretty well of the ridge. Why? Why are they doing well? It goes back to this. The palatal bone is thick. 2 reasons. The palatal bone is thick and has marrow, and we don't often open the palatal flap to get access. We open the buccal flap. So that combination keeps this crest here, so even if this is going to resorb, as you'll see it does, the ridge itself doesn't lose much height. What do we lose? What do we lose? What's that? The buccolingual dimension changes. Big time. In fact, it's huge. This is not a minor amount. This is what's destroying us and why we're seeing recession on our cases, because the vertical ridge isn't so bad. That seems to be pretty universally good. Look at these numbers buccolingually. This is unacceptable. That's going to show. The average being almost 4 millimeters. Wow. That is huge. That means that the ridge that's here, if this is the buccal, this is the lingual, after this is healed, I might have the height of my ridge, but it's all the way in here. The buccal's gone. It's 4 millimeters in. In a recent consensus conference, Hammerly and a group of top experts said the average bone loss based on the literature is 3.8 millimeters buccolingual dimension change in an extraction. I question it. I now am going to tell you that that's not always true. What do I mean by that? When I went back and looked at this literature, what did they all do? They open flaps. That's what I realized. So that is true. Those numbers are very valid. Those averages are valid if you open flaps. What happens if you don't open a flap? We have some top experts in the room. What happens if you don't open a flap and you just take the tooth out, you don't do anything there? What dimension change do we see? Do we see 4 millimeters? As you will see before we finish today, the answer is no. We do not see 4 millimeters. How much do we see? 1.5 to 2, even less. About 1 millimeter. Now, there's very limited data in the literature. The data I'm going to show you is just being submitted for publication. But you look at what's out there already. Here, this is what's out there. We don't have good data of what's out there if you don't open a flap. There's a couple of articles. Uli Grunder just recently came out with an article showing an immediate socket with a connective tissue graft or with nothing. The nothing one is what's interesting because he didn't do any flaps. And he just put an implant in up the palatal wall and put a healing abutment on. And he looked at the dimension changes afterwards. And what did he find? Dimension change, 1 millimeter. Not 4. 1 millimeter is something you might be able to live with. 4 is clearly not in the aesthetic zone. So we have a big difference. And it was all difference of just opening a flap. Now I'm going to verify what Grunder showed with our data with many more implants and with 2 different offices. The data I'll show you is from my own office with all of my team and with Garber, Salamer, and Marie Salamer, and David Garber, and Henry Salamer. So we combined our data to get a bigger N value, as you will see. And what happens if we deal with the gap also? What if we put something in the gap? Does it change it? Does it make it even better? Well, less bone change. Yeah. And what if we make it temporary versus a regular healing abutment? Does that change? What happens if we put a bone graft in the gap? Does that make a difference? As you will see, the answer to all those questions are they all have some value. But the most important value to remember is going from a 4 millimeter average down to about 1, as you will see, buccolingual dimension change, just by not opening a flap. So when the buccal plate's present and you don't open a flap, we start to realize that we're going to see minimum change, as you will see. Here's the Grunder article. And this was recent. This is 2011, just last year. And he did a connective tissue graft, which I am not recommending at all, and you'll see why, versus nothing. And what did he show? The implants were placed normally 3 millimeters up from the free gingival margin. The control, 12 cases, the loss was only 1 millimeter. That was it. Buccolingual dimension was 1 millimeter change. He did gain about 0.3 of a millimeter if he did this violation of the buccal, but I don't like doing that because it opens the periosteum up and not all of them will last and survive. And if you don't need it, and it looks good beforehand, I don't think you need to graft at all. So this is the article in International Journal of Period and Restorative Dentistry. That 1 millimeter is the beginning of the whole start of our discussion, because that's what we show, as you'll see in a little while. So if you do connective tissue grafts and tuck a piece of connective tissue underneath there, you have sometimes necrosis. You take a look at this article, and in 10 cases, 2 of them necrosed and actually caused gingival recession of 1 to 1.5 millimeters. So putting a graft in doesn't always mean that you're going to have clinical success. If it's there, leave it there. Don't even disturb it. It's a new article that just came out. It's a little more detailed than we have to get, but they showed basically the same thing. This article, this is a recent article by was it Brownfield, I believe it is? Yeah, Brownfield. 2002, it just came out. It's a new article. And what they looked at dimensional changes in the Journal of Periodontology, and they looked at alveolar changes with this, and they looked at hopeless and restorable non-molar teeth in the anterior part of the mouth. And what they did was very interesting, but most importantly, they measured they put a stent over the top of the tooth, and they measured from this point to the buccal plate, and they sounded that. And they looked at this difference, and I don't want to get too technical, but at 3 millimeters up, which is about the crest, they realized that the change in the buccal was what? What do you see there? 0.9. So the bone, it was only 0.9 changes, which goes along on the buckle to what we've been saying, that we don't see much change, okay? So sometimes you see lesions like this, and this is this case. And this patient had an immediate socket placement, and the papilla were fine, but look at the midfacial. Repeated infections, and she was placed 2 years before by a dentist down in Louisiana, and she didn't understand why it receded. She doesn't like that. And she also was getting chronic infections. And when I opened it up, that's what I see. Now, periodontally, should I save this? Can I save this? Can I save this tooth? Every periodontist certainly knows in the room, and many of the oral surgeons knows that this is very fixable. This is an 17-year-old boy where the orthodontist moved the tooth too far out, just dehissed the whole root. Can I fix that? But he didn't want to go back to orthodontics and move it back. That would have been ideal, and then graft it. But can I fix that? Yeah. 6 weeks later, it looks like that. Double papilla flap over the connective tissue graft, and you can do that. This is treatable because there's no other disease present except a recession. There's no interproximal disease. Now, this one is different. You say, well, you could do that on a tooth. Do it on this implant. A lot of you restorative dentists, you know, you work with some great periodontists and oral surgeons in the room, say, well, fix it like you do on a tooth. The problem is we can't predictably clean that. That's not a tooth. That's a toxic, infected implant. It's not a fresh implant. It's been in for 2 years, and it's been chronically exposed to bacteria. So I used to try to save these and build up the tissue and build up the aesthetics. I now take these out. I don't play with them anymore. Not when all these threads are there, and here's the key, and the implant, and the crown has to be changed, and the implant is in the wrong position. Because every time this is coming out the buckle. And that's why this recession took place. Besides the infection, when the tooth is infected and it's coming out the wrong position, even if I get rid of this and I hold the implant in, and this was an 18-millimeter implant. The guy had a beautiful bone up here. The problem is there's still a trough all the way around here, and it wraps around, like I showed you. So the question is, can I predictably fix this? The answer is no. Now, my good colleague and friend, Stu Froman, just recently published an article with like shotgun therapy, all kinds of stuff, you know, cost you more money to try to repair this than the implant was to begin with. You know, using all different kinds of growth factors, modifiers, membranes, everything. And he shows 34 successful cases overall. But the problem is aesthetically here, you're going to still have a problem. Even if you get that to fill with something, you're going to still have a problem because it's coming out the buckle. And every time you put an abutment on, it's going to move up. So even if we can fix the first problem, which is the periodontal problem, we're not going to fix the recession easily. So those come out. So these are the two papilla problems that we see. These are just horrible situations that we see over and over again. So the golden rule, do all site development before implant placement in the aesthetic zone. Garber showed us that almost 18 to 20 years ago. And I'm known for this statement, do one miracle at a time. So let's see how this takes us in a type 1 case. Let's start doing some dentistry now. Let's start looking at what we do with a typical good case, a case that comes in and has everything we need. Look at the tissue. She shows everything. It's moderate scallop for sure. It's not thick flat. It's more in the moderate zone. When you take a look at this, she's got some external resorption here, and it's eating through that tooth. You see it's discolored. It's been treated with endodontics. You can see the problem right there. Now, what do? This is not endo versus implants. Endo is a very high success rate. It's not an endo problem here. This is not an endo problem. And it's not like we're competing with endodontists. That's a ridiculous statement. They have a very high success rate, especially with microscope work. It's same 95 to 97 percentile success rate. So the question is, what do? If I wanted to get in here, first we'd have to change this, bleach it, and I'd probably destroy this papilla trying to seal this off. So we all looked at it from multiple perspectives, and we decided to take it out. So I took the tooth out, as you see here, kind of an interesting little bubble. I took it out as atraumatically as possible. Did I open a flap? No, but this one's easy because the roots are still on. I mean, no, the crown is something to grab onto. What happens when the crown is missing? And I'll show you that in a few minutes. You know, we don't open flaps. It's a different head trip. Everything is through the socket. Listen, today our medical colleagues are all minimally invasive, aren't they? And they're even changing heart valves through small openings now, right? You know, instead of cracking open a breastbone, they're going through arthroscopic surgery to replace even some heart valves. If they can do that, we could certainly get a damn root tip out through a socket. Is this rocket science? No. Look at picture the socket is this big, wide open opening. mentally. Look in there. Oh, my God, look what nature gave me. I took the top of the tooth out. Yeah, I got a broken root tip, but look how big that space is. I don't have to come in with arthroscopic surgery. I can look right up the chamber. And yes, it might mean some new machines and new technology and new burrs and new elevators, but we have them available to us. Let's use them and not open a flap for our convenience. Let me ask you this. If I broke your root tip off taking that tooth out, I don't care if it was just the root tip or half of it, and it was your mouth, would you prefer that I open a flap to get it out in your mouth, or would you prefer that I work through the opening and got it out that way? Let me guess. Any takers here? No. Oh, Dr. Tano, please open a flap on me. Absolutely. Of course you wouldn't. So let's not do it to our patients. It's rethinking mentally a technique, a way of thinking. I haven't opened a flap to take a tooth out since the year 2000. That's 12 years now, unless it's impacted. Unless it's deficient, I want to do other things to the area. But when nothing's deficient, I don't touch it. Minimally invasive. That's the key. So where do we place it? And this goes now to our platform switching discussion. This was not a platform switch implant. Now where do we go? I always use the cingulum as my guides for these 6 anterior teeth. Central fossa for the back ones. Now, we're going to go up the palatal wall and try and do that. Now, you notice it still moved a little bit labial. It's still going to be on the cingulum area, but it's going to be a little bit labial because every implant that you put in, when you hit this palatal wall and there's no reciprocating wall because of the gap, it moves in. You've all seen this happen where you're placing the implant in, you got beautiful right up the cingulum area, and suddenly at the last few turns, the implant moving forward as it's going in. That's because this is the outside of the implant's hitting this wall, and there's no reciprocation. So that's why we start with the cingulum. That's the proper place to place it. Now, what else? So you asked about the vertical positioning. I think it was you. I didn't forget that question. So when you look at that, where did I place this? I placed it 3 millimeters up on the labial. I placed it 3 millimeters up on the labial, sorry. But I placed it 2 millimeters back, more or less, to the cingulum. So this is the rule of thumb. 3 millimeters up from the facial height of tissue. We do that for what? Aesthetics and running room, like you said. But what does that do in the anterior section? It violates the interdental bone. Look at how much. What's the typical scallop of bone in the front of the mouth? In a central incisor. What is the typical scallop of bone between the midfacial and the papilla bone, and under the papilla bone? About? Well, that's 4.5 that's the soft tissue. That's the scallop of the soft tissue. But what is the average? About 3 millimeters. So 3 millimeter scallop between the midfacial bone and the interdental bone. And what you see here is exactly it. I'm at the midfacial bone. The height of this implant is the midfacial bone. But look at the interdental bone. Am I below it? Am I apical to it? Yes. About how far? About 3 millimeters. So this implant is placed perfectly from a height point of view, yet it has violated the interdental bone. And every one of your implants will do the same thing. So whether it's platform switch or not. Now, this one wasn't platform switch. Now, I get away with this case. Why? Because I'm more than 1.5 millimeters away from the adjacent teeth. And I'm more than 1.5 millimeters away from the buccal plate. Now you got the spatial relations. So in this case, it didn't matter. Would it be nice to do a platform switch? Yeah. Would it preserve the bone? And I wouldn't have had to worry about being too close to the adjacent teeth. So we discuss this. We take the tooth out, place the implant in. In the middle is one option. For cementable, that's fine. Screw down, it's not so great. But this is the worst place to put it, up on the buccal. That's number one disaster. You're coming too far out the labial surface. That is a big, absolute no. You're too close to the buccal plate, you're going to resorb it, and you also contour, the crown will be over-contoured, and you cause recession. That's absolute zero no. So the middle is okay. The best place we feel to put it is slide up the palate. That way you have options of screw down or cementable. And as you're going to see, for immediates, we prefer to do screw down, provisionals, even if the final crown is going to be cemented. Why? No cement during the healing. And the tissue will reach its own height, as you will see, tissue-wise. Watch this. So we go up the palatal wall. Sometimes we got to perforate through a few millimeters up here and engage that palatal wall, and we stay there. And we might kick forward a little bit, but that works out pretty well. And then we take the PEEK material, what every company has, a temporary cylinder. We take that, and we have a shell made already, and I'll show you step by step how to do this. But we take these two things and wind up with this. That's what your temporary should look like. Not a piece of garbage. Forgive me. But some of the things I see, not from anyone in this room, but some of the things I see are so atrocious. and people call it a temporary. It's not a temporary. It's not even, it's a shame that we even let a person walk out of our office with some of the things that you and I have both seen. So, but why is this critical for the restorative dentist in the room? And we'll get to how to make these two pieces, this and an outside shell, how to make it into this. I'll show you step by step in the case I did this with Steve Chu, one of my partners. We did it step by step to show, because many people didn't say, how'd you get it to look like that? And it's not hard, but you have to know how to do it. It's straightforward, but we'll do it. The point that I'm making is that there's two things here. One, this is supportive of the tissue without being too distended. We just want to replace what we took out. So that's what we're trying to do. Not too flat, and certainly not too contoured, over contoured. We don't want to cause recession. It should be supportive and keep what's there. And this is the contour of the teeth that match the adjacent teeth. So we take the core, we hollow it out, make a hole in the back of the shell that we have, and then we attach the two, and then outside the mouth we fill in the voids, and we make this. And that's, why is it so important? Tissue will have to take this shape. You have an empty socket. So you, the restorative dentist, are designing what shape the tissue is going to take. You are, not the surgeon who did the case. You, the restorative dentist, will design this. And so this is what it looks like at day one. That's the day of the extraction. This is what it looks like 4 weeks later. So I know you're thinking, oh, well, he got lucky on one case. You know, I'm going to make you sick looking at case after case today, because this is what we see all the time. Maybe a hair recession, sure, I'll show you some, but no, we're up to the 4 millimeters. This is only 8 weeks. Let's keep going. Here it is 13 weeks. It's as if we did nothing. This is when the buccal plate is present. That's 13 weeks. Now, wait a second. We took this off, and what do we see? Bleeding. Now we understand what the bleeding is, don't we? You see, in this case, no graft. We'll come back to the graft later. No graft yet. This is just provisionalization, holding the tissue out, and nothing in the socket. Do you see 4 millimeters of change? In fact, we measured this as one of the cases that we're going to measure over 50 of these cases, and this one only changed a 0.5 millimeter. Compared to the contralateral side, which was not touched. All right, what's the bleeding? We had epithelial adherence to the implant, to the crown, the acrylic. And one of the first things I asked when I saw this, I said, Steve, take this picture right away. Show that. That's a great picture. Because we don't always see this. When we do see this, we get our best results. Why? Because during the healing, we're getting physical support in a more coronal position. These are where we actually have measured this now, and we have our best results buccolingually when we do have the bleeding when we take it out the first time. If we have no bleeding when we take it out the first time, we saw our less beautiful results, meaning that we got a little bit more collapse in. It's tenths of millimeters, but we definitely show a difference. So how do we get that? Well, the first thing we realized is that before this temporary went in, I said, what's the last thing you guys do? I asked all my partners who do this. They're all doing it. And they said, well, we have our own laboratory. We have 9 technicians in our office. And so we have our own steamer and everything. Now, how many of you have your own steamer? Most of you probably don't. How many of you do? A couple of you, 2 or 3. It's about 3 to 5% of the population of dentists have a steamer. But it's right at the door of the lab. And as we go out the door, they go, pshh, and steam clean it. Now, it's something as simple as that, as I mentioned, may get any of the gook off, all the stuff from our gloves, and get this clean so that when we put it in right away, screw it in, the tissue has the ability to adapt right to a fresh, clean surface. It's not perfectly sterile, but it's not filled with all kinds of polish and everything else, okay? And we think that makes a difference, as you'll see. Then you have a custom abutment. You just put your impression coping in, and you do some GC pattern resin to do a nice pickup. And here's the final crown in place. And you can see that we don't see 4 or 5 millimeters. In fact, I told you this was a 0.5 millimeter change. And so we see these kind of results routinely, and this is what the bone looks like. Now you notice there's not a platform switch, but nothing happened to the adjacent bone. Why? Because I was over 1 millimeter or so, 1.5 millimeters away. So even without a platform switch. Would a platform switch give me a little extra security? Sure, as we discussed. Fair enough? And that's what we look like. And here's the contour, and you see that we don't see these major changes as was defined before. Any questions on that? So let me take you through. Huh? That was a 3i implant. There wasn't a platform switch. It was a regular 3i implant. That was not the tapered one. That was just a straight one. That's 3i. full osteotype. Okay? But we're going to lose bone a little bit down the side because there was taking off and there was no platform switch. But that's 3 eyes. Regular implant, not tapered implant. Let me take you through this case. We'll tell you step by step what we do. The restorative dentist in the room in particular, Jeff? Yeah? No, we haven't seen any difference at all. Because here's the key. The epithelium seems to still adhere to this material and can move with the tooth, even though it has a little more give to it, the peak. Just like your tooth right now on your enamel or on your dentin. The gingival margin moves with the tooth. Bone doesn't adapt, but the soft tissue, as you know, moves with the tooth. Trauma from occlusion doesn't cause recession by itself. It may get a widened ligament space, but the epithelial attachment moves with the tooth. And we see the same thing with implants. The epithelium stays on the abutment or wherever you get the initial seal, so it doesn't seem to be a factor. Does the surface texture of the temporary, soft tissue will adhere to a smooth or polished surface, whether it be titanium or acrylic. What we need to make sure it's not toxic. No endotoxin, no debris, no polish on it or anything. And that's all that seems to matter. Long term, it may make a difference if it's too rough. It may make a difference that it may be a plaque problem. But in terms of the initial epithelial adherence, we've not seen a difference. This is where the laser etching comes in. We're not sure whether or not all the companies should do something like this or not. 3i has a study that showed that they used osteotype-coated abutments. It was about 5 years ago. They did a study in animals. And basically, there didn't seem any harm. But, they didn't really look at the epithelial attachment level. They looked at there was no harm, there was no greater inflammation. That was when they deliberately put osteotype on abutments to see what effect it would have. So it's something to maybe relook at and see whether or not you have more epithelium or less epithelium. There is some data with the laser lock that says that the amount of epithelium, the biologic width, had less epithelium and more connective tissue when you had the insertions of some openings into the abutment. So this is something we still all have to look at. It's still in the beginning stages almost of whether or not this is positive, negative, or no difference at all. We don't know. Okay? So let me take you through this case. Now this woman, this guy had a fracture. As you see right here, he's got a fractured tooth right through. And so we're going to take this tooth out, even though it looks okay. We have to take it out because it's fractured halfway up. So let me show you step by step what we do. The first thing you do, if you're caught in an emergency, the guy just walked in and fractured their tooth, you don't have a process temp. If you have a process temp, great. You make a shell and you have the process temp. But now in your own office, what do? Take a snap alginate of this case, take an alginate impression, and so you have the shell. That's the alginate, and then take some Nylon powder and liquid. We use Super T acrylic. It's very fast setting. And while we hold this, we just add into this, make our own shell. So we kind of roll it back and forth. Even our assistant has been trained to do this even. And while we're working on the case, now that we have the alginate, we fill this with acrylic, just the shell. And it comes out, it looks like this, with the extra flash. Okay? And then we trim off the excess flash, and now we have our own little process temporary. So we made something quickly right at the chair for an emergency situation. Okay? So that's what we do there. So you can use an Omnivac too, I guess, if you want. Now use a small blades, 15C blade, as you see here. And don't use a 150 or 151. We use these instruments that now have peaks to them or little thinner tips. Titan forceps, Salvin makes a deep gripper. If you use Salvin, the deep gripper, something with a little extension that goes up into around the ligament space to grab root tips better. Now here, this is more typical now, right? It fractures off, and now you don't have anything too much to grab onto. So this one still had enough to grab onto that with this little extra tip, I was able to get this out. Now how do we get this out? We do not, if we get a purchase with this forceps, we don't go buck or lingual until it rocks and breaks the buccal plate. Those days are over. It's rotate and out. Rotate and out. Now, central incisors are easy because they're more round, but you can do that with almost all. Break that ligament by rotating and pull it down. Not, let me push it until I get it out and stretch that bone and stretch the ligament, because that just fractures your buccal plate. So, this is rule number one, rotate and out. And in this case, I still had plenty to go. I'll show you what I do when I don't have anything to grab, or if it's higher up. This case, I was able to grab just enough to be able to rotate and pull it. How clean it looks. And and we go and clean all the apical area out, and we spend time cleaning that apex out, make sure that all infection's gone, and we really debride that thoroughly, irrigate it, and debride it again. Now, in this case, I put in a 5-millimeter implant. That's a 3-eye implant, and we put it about 3 millimeters up. There's the peak material, and we kind of adjust it so that we have a hole come out the cingulum. Now, here's the shell that we made. Now, here's where you, the restorative dentist, have to come in big time. You open this as wide as you have to get the peak material to come through and the front of the shell to still look in the right position cosmetically. So then after you've opened it up completely and you know you can seat it properly, we then add acrylic to this, and seat it home. Make sure that no acrylic gets in the opening. And we seat it home, and we've opened it up wide enough so that this can be seated all the way. A little Vaseline on the adjacent teeth, and that does it. So we're positioning it perfectly in the arch. Now, we wait till that sets, and then we unscrew it. And now we have all kinds of lumps and bumps. We attach a lab analog so we can hold it. And now we have lumps and bumps and, undercuts and everything. Wash off the blood, and then you start filling in these undercuts with acrylic. We can mark the adjacent contact areas with a pencil. And notice this is not what we're going to put in. This is nothing like the crown that we're going to put in. You got all kinds of stuff. We're going to have to trim this down. We're going to have to add here. We got undercuts here. Now we start adding acrylic to all the undercuts, as you see here. See these undercuts here? They have to get rid of all of them. So we add more acrylic outside the mouth. And you see it's starting to fill in here now. Add more. And then once we fill up all these voids and we let it set, then we take our stones and we start to trim it down. And so, we start using whatever you like to try trimming your acrylic. Heatless stones and wheels and burrs, as you see here, to start getting your contour. Then we can add a little extra shine or a little extra peak material on the outside, and notice how nice and smooth it gets. And it looks more like this. And we put it in, but this was a little too trimmed back. So what do? Take it out and just add a little more acrylic and give it a little more support. And that's what we did here. Taking this time to do this properly now. That's how we went from two pieces of an empty shell and a peak material to this. This is what your temp should look like. This isn't just for prosthodontists. This is for everybody in this room. This isn't full mouth rehabilitation. You should take the time to do this. If you do this right at day one of the day of the extraction and your implant was placed in a proper position, you are golden. You have done your work and you're finished, because you're going to guide where the tissue comes back by putting in this kind of a temporary. The tissue can't grow where there's something in its way. It's called contact inhibition. And so you were designing the exact shape of the sulcus. Then you just duplicated the final crown. It's as simple as that. Spend the time now. You don't have to start pushing it later and sculpting it out later, right? This is for sockets. Then you can do some minute stain, just to give you a little extra color. And here's what it looks like when it goes in. Now, what do we do today? What we do today is after that's done, we take different graft materials, and we'll talk about which ones to use later today. But this one happened to use BioOz collagen, but we use Puros, we use Regeneros. Regeneros is good also. It works very nicely into the gap. We will discuss the gap as a separate entity. But we're basically putting these materials in. We'll put the straight cylinder on. Now the temp is made already. And we put the straight cylinder on. Now I need access. When I put the temporary on, I don't have access to the front. So we take it off. It's already done. It's made. We put the graft material in and pack it against the straight cylinder. Now, one of the things we're going to talk about, it'll probably be after lunch, is where do we pack to? Do we just pack up to the crest, or do we pack supracrestally too? As you will see, I'm packing supracrestally in most of my cases today with these small particle mineralized bone. And we're doing this because it's what I call dual zone socket management. And the dual zone is what? There's the bone zone and the tissue zone. Now, we used to only concentrate surgically on the bone zone. The gap was filled up to the crest. Now I'm suggesting something different, and it's still in the early stages, but we're suggesting grafting both zones. And then what happens? You put this in, and the excess, now you have your temporary, it's packed. See, now you take your cylinder off that you packed it against, and now it stays there because the bone graft we're using, like Regeneros, BioOz collagen, Puros, any of these graft materials tend to stay where you put them. And so they get that initial stickiness to them. Then you take off the straight cylinder. Now you have your temp ready to go in, and you squeeze it up, and all the excess comes out. And you take off that excess, and this is the way the patient walks out. That's day one. Okay? And this is what, like Lindy and Arojo showed, that you can get these particles in here, and they just seem to be encapsulated inside the bioas particles or in the tissue. We'll come back to this later. And here's like here and here, you see some of these things. Now, this is what it looks like, as you see here, the same day of extraction with the graft in. This is what it looks like in 1 week. It's done. It's only 1 week. Certainly, you've got to wait about 8 weeks to see what your real tissue shape will be. So let's wait. Here it is, 2 months. Now, we got a hair of recession here, but nothing critical. Nothing critical. And you can see that the shape up here and the shape down here is pretty near zero change. And so this is what it looks like now. We're ready to take impressions. Here it is at 4 months. And you really don't see this 4 millimeters of collapse, do you? Maybe a few tenths of a tenth of millimeter. 1 millimeter max is what we're seeing. And when we graft to put the temporary on, it's about 2/10 or 3/10 of a millimeter, not even a full millimeter. So the grafting of this gap is allowing us to keep support of this tissue combined with the provisional, allowing this to look really good. Here it is at 4 months, and you can see we've really kept the shape really nice. And now we're ready to finish the case. There you see it. Then put a custom abutment on, a GC pattern resin. You can do some GMAS to make your soft tissue model so the lab knows what to do. And then you start making your porcelain on. Here's the layering. Adam, our technician, is adding the porcelain and staging it. So it's layering it so we can get some nice internal color. Here you see it, a little bluish at the first try. The first try is a little deficient, a little too blue. It's not bad. Then he adds a little more yellow color to it. And we also will gold plate the abutments. This is a cementable case. We're going to gold plate the abutments on the inside just to give us a little extra color stability. And here you see it in the mouth. And here's the final case. You know something? Once we have this done, part of it, our lab, Adam does so many of these, we do so many of these cosmetic cases. He's the main guy that we use to do these, showing essentials, showing you the hardest cases, right? One central to another. And so Adam's our main porcelain technician for the final cases, and he's just backed up. But you know what's nice? When we put nice temporaries on, like what you saw, nobody's hawking us. Nobody's banging our door. I can't stand the way this looks. Get this out of my... You know something? It's not even a factor. We don't have people banging our door down, get this out of my mouth, get that temporary out of my mouth. Not with these cases at all. We spend the time to do it, like I showed you, and the case looks nice. So it's just a matter of when we want to finish it. So usually we wait 2 months minimum, but for sockets we usually go a full 3 months. Depends on how big the gap was, and how much apical bone there was. So I want to give it time, but there's no rush now because the patient's not walking around with a flipper. And they stay away from it. It's out of occlusion. Out of occlusion for the first 2 months, and they're told to favor it, stay away from it. Now we have to have good stability. At least 30 Newton centimeters torque is minimum. Usually it's 35 or 40. With these self-tapping tapered implants that I've been using with 3i for about 4 years now, it locks in magnificently into the apical bone. And so we've had very few loosen with the patient sometimes forgetting. Has it happened? Yes, but we have enough stability that if a patient forgets and touches it or bites into something, it's still stable enough to hold. That's what's nice about these. Now, other implants have the same thing, or so, but actually not all of them have the stability. Not all of them, if you allow them to heal, with any textured implant, we have a good success rate. But not all of them have the same initial stabilization. They're not as self-tapping. Most of the companies are now first trying to get that. But some of the companies don't have the self-tapping nature that you do see in 3i, I have to say that. And that's the main reason I'm using it. It gives me tremendous initial stabilization, that tapered implant. And you can see that we don't see 4 millimeters of change. In fact, I barely tell you that this one was about 2/10 of a millimeter when we measure compared to the contralateral side. Right? Would you accept that? That there's no 4 millimeters of change buccolingually? I think so. And this is the final case in place. Okay? And there's the implant platform switch. Didn't get all the attachment here, but we'll see. But there's the bone graft in there, and we'll do it. All right? Now, what do you do when there's when the soft tissue is present but no buccal plate? Now, this draws a whole different question up. Here's the main reason that we have to differentiate this, because there's part of the buccal plate's missing, which means what? You can have recession, an increased chance of recession. So all the cases I showed you so far, though I showed you 2, but all the cases I'll show you with immediate sockets all had a buccal plate. That's the real key. So when the soft tissue's there, but the buccal plate's partly missing, greater than 5 millimeters loss. In other words, I mean, if I could probe from the free gingival margin from here, if it's 3 to 4 millimeters is normal. If I'm 5 or more, certainly anything more than 5, no. That's a type 2 case, okay? So 3 is the normal crest. A millimeter sulcus, 2 millimeter biologic width. So 3 is the normal crest. 4 is certainly fine. You get to 5 or more, certainly more than 5, that's type 2. So 5 or more, you're in nowhere's land, not in a high lip line. Be careful. Fair enough? People ask me that all the time. And this is the perfect case. This is the case they used in the article that I did because it's a perfect case for teaching. Why is it a perfect case? Because you got extra tissue here. And you guys look at that and say, hey, Bob, hey, Mary, let's do that immediate socket stuff. Okay, let's do that immediate socket stuff. Look, we got even have a little extra tissue in case we get some recession. We're going to have a little extra tissue. It should be great. What's the problem with that thinking? I could take the probe and put it straight up the buccal on this case. Doesn't look like that, does it? But I could. Take a look at the x-ray. Now you understand. There's a huge granuloma. There's a fractured tooth here, and it's draining right down the buccal. Now, it's thick tissue in the front, so you don't see it. You know, you don't see the redness. But I could take the probe and put it right up here. So is this the case to do, even though you got a little extra tissue because it moved down compared to the other side? No. So the word is very simple. No buccal plate, no implant. It's as simple as that. You remember that or else you don't get lunch today. No buccal plate, no implant. No buccal plate, no implant. You drill that in your head as a team, and don't sacrifice. Oh, she would want the temporary. Yeah, but so you're a winner. So you put it into the apical bone, you put a temporary on. That's great. So you're Dr. Tana, you're so good. I love you. Give me a kiss. Okay, great. Thanks a lot. But what happens 2 months later when you got mid-facial recession? Dr. Tana, you didn't do the right thing. But you didn't want to wear a flipper. Yeah, but you shouldn't have put it in if you would have known that I didn't have the recession, right? Huh? Now it's your fault, even though you were the hero the day that you took the tooth out. Be careful. Be careful. It's happened to every one of us. We want to help our patients, and in doing so, it comes back to bite you. When will it bite you? No buccal plate, no implant, not that day. Now, there's a couple of different ways to deal with that, isn't there? And I came up with, to me, the KISS principle. And I came up with, after you thoroughly debride the socket out, I didn't want to lose the shape. So I said, how can I do that? When I put something inside the socket, I can help keep that shape and start rebuilding the bone. And I figured just a little temporary canopy over the top to prevent the particles from coming out. So I called this the ice cream cone technique. It's upside down. There's the ice cream, and there's the cone. And you can see I like ice cream, and so I figured like food, so I figured I'd give it that. So you can hold it there. You shape it so that this is the shape that fits inside the socket, and the part goes up inside inside the outside of the socket, and the part goes in, fills up the void. Small particle bone, regeneros, small particle mineralized bone is preferable, and we pack it in firmly. And when you pack it down firmly, it pushes this tissue out, and it pushes it out, so this keeps this membrane in. Now, you cannot do this with every membrane. Like a BioGuide, for example, which is a popular membrane by OsteoHealth, is not for this procedure. BioGuide is not good, because when it gets wet, it becomes like a wet noodle. You have to, and it tears when you suture. You can use the OsteoGuard here by 3i. You can use Zimmer's Biomend Extend or the socket repair membrane. Those can be sutured and they can be placed, and when they get wet, they just don't fall over on themselves. So you cannot use BioGuide. For other things, sure, BioGuide's fine, but you cannot use it for this type of procedure. People say they tried it, and they said it was a pain in the neck to do. What membrane did you use? I used BioGuide. Okay, you can't do that because it's not suturable and it's not manipulated. You have to have some resistance or resiliency and hold its shape when it gets wet. Put one suture here, 2 on the sides, and you're done. So it's basically to try and maintain and not to lose anything. So we take the tooth out, we put it inside the socket. And everything is really geared from here to here. You want to prevent this tissue from filling in the graft. So this is going to resorb and fill in with bone no matter what you do. All the walls are there. Everything is from here to here. So we put the graft in and then flip this over. It's already shaped to fit right inside the socket. This is what's going to happen. This is going to resorb and fill it with bone. This is only a canopy for about 10 days or 2 weeks. The salivary enzymes will destroy this, but the part that's covered here, this will prevent this membrane will do guided bone regeneration and prevent this from penetrating in. This will take, though, 4 months to regenerate a buccal plate, not 2 months. It'll take 4 to 6 months, depending on the size of that lesion, to really fill in with bone and form your new buccal plate. So that's what it looks like. So from, let's see if we can get this going. So from a diagrammatic situation, intracellular incision, remove the tooth, excuse me, long root, thoroughly debride the defect, now this should be wider. This should be enough. This is a mistake. This should be wider from this diagram to cover the defect, right? So it blocks the soft tissue from penetrating into the defect. Squeeze this up. You might have to hold this while you do that. Hold it with the college pliers when you tap it in firmly, not lightly, firmly. And that pushes this out when you do that, it pushes the tissue out. And then this is already pre-trimmed to fill it inside. Then you just put one suture in the middle. It'll show the side, but you put one right down the middle to start, and then one on either side. So put this first suture in the middle, it'll be easier, and then place the 2 on the side, and that's it. So that's what we tend to see, and it looks like this in the mouth. Now, we just did a flipper in this case. Notice at 2 weeks, the membrane's gone, but this is where the work is being done, right here, and acting as guided bone regeneration. Here it is at 2 months. Now, at 2 months, so you take an x-ray, it looks good, but that's just bone particles. That's not new bone. At 2 months, with the buccal plate missing, it's not enough time to form the buccal plate. So don't go back in just because the soft tissue is covering it and the x-ray looks good doesn't mean that you can go in there. At 4 months, I went in. After I sounded the bone, I had enough. In that case, I was able to do a punch. I had enough shape. I did a punch, put a zirconium abutment on, packed some cord, and there's the final crown in place. So we can do this even when the buccal plate is missing.